Joy 99.7 FM. That's right. You know who you are. That's why you're on 99.7 FM. With me, Norte by nature. 29th October, gone by, yes. World Stroke Day. So today I've got the team from the Kalibu Teaching Hospital Stroke Unit. You know he's another Dr. Ato Acquah, consultant neurologist, head of neurology at the Department of Medicine. Kalibu Teaching Hospital, Cynthia Oseyeboa is a physiotherapist with the unit. And Monica Pierre is a matron with the stroke unit, Kalibu Teaching Hospital. We're going to be learning about stroke, what it is, very serious medical emergency. We play many games with it. We deny it's even a stroke. And then when it's properly diagnosed, we play games with the management and the medication. If you have any questions, concerns, 055 11 11 997. We're live on Facebook and YouTube. Ultimate Health. Albert and team, you're welcome. Right, it's been a while since we've had you in the studio, Albert. And in fact, the stroke team. Last year, we didn't have the honor of having you in the studio. Yeah. But stroke continues to be a very, very serious problem. So you're welcome, and having you sandwiched between the two ladies. So I'll start with you, Albert. Okay, you know, many people, we hear stroke, oh, so-and-so had a stroke, this is a stroke, but we're not too clear with what exactly it is. I know it's a brain event, but tell us, from your side, medical, what is a stroke?
So a stroke basically is a neurological deficit, which occurs when you have either a hemorrhage or there's a clot of blood or a vessel bursting in your brain, or you get a clot in your blood vessel. That is, you get an infarction, that is, no blood enters that part of your brain. Okay. So either of the two of them, whether it affects your brain, your retina, that's the back of your eye, or your spinal cord, that is the new definition of stroke. Okay. And unfortunately, worldwide, the definition needs imaging. That is, without an image or without you confirming what type of stroke that is, you cannot treat or you cannot give the appropriate treatment for that. So that is why this year the hashtag or the theme is hashtag precious time. Right. So precious time saves lives, space saves lots of things. So it means that we need to get there on time. Right. Time is brain. Right. So no dilly-dally, no traffic, no ambulance, no CT scan. We said last year that every region should have a CT scan. Okay. We have no excuse whatsoever. Right. So I repeat that again. Hashtag every region must have a CT scan to be able to make the diagnosis of stroke. Otherwise, we are wasting our time. We are not catching up. Okay, great point. So a brain event, some part of the brain is short, compromised blood supply. Yes. Either a blood vessel is blocked or it has burst. Yes. All right. And then you expanded the definition. You talked about the retina and the spinal cord. The spinal cord. So that's the new definition of stroke. Right. Involves a vascular event in the brain, the back of your eye, or your spinal cord.
Okay. Right. And then you make it clear it requires conclusive medical diagnosis,
yes.
which cannot be done in the absence of medical imaging. Just quickly hit those points so that we understand.
In the past, we used to conjecture, okay, somebody comes with a blood pressure of 130, 220 over 100, so we assume that is a hemorrhagic stroke. So we go this pathway. But that same person can have an infarct, and we miss giving the person aspirin or doing the immediate therapy, which we can do. That's thrombolysis, busting that clot. So you need to be in the hospital within 3 hours to get that done. So
within 3 hours of the event?
Of the event.
All
From time of diagnosis, time of the stroke, time of diagnosis, time to CT scan, time to a unit where we can treat this, 3 hours.
Okay.
So that is the hashtag save precious time.
Right. And if we can make it within this critical time
then
limit,
we can remove the clot. If it's an infarctive stroke, that's where there's a clot which we can go and remove or melt for the blood flow to go back to the area and restore function.
Okay, great. If you just joined us, you just heard speaking Dr. Ato Acquah, consultant neurologist with the Kolebu Teaching Hospital. He's here with the stroke team or members of the stroke team. Next to him is Monica Pierre. She's a matron, which is a senior nurse with the stroke unit. And Cynthia Oseyeboa is
the head of physio.
She's the head of physio. Okay, I got heads in the house, right? Me, I'm just the head of talk. I just talk, but I make sure that it informs and transforms. If you have any questions on stroke, the causes, your experience, the time, critical time factor that Albert is talking about, he said there should be no excuse across the country, and he's expanded that definition as well. You can WhatsApp at 055 11 11 997. Okay, so we get a person to a center, but people want to know, so how would we know that somebody is experiencing a stroke? Before I bring in your colleagues, I mean, what will we see to mobilize the action, the timeous action you're talking about?
So there's an acronym we call FAST, FAST.
FAST, right.
So you can practice this yourself. So everybody give yourself a smile.
Okay.
So you to smile and both sides of your face should show. If one part is drooling, one part is drooping to one side, then you may be having a stroke.
You should be able, hang on a sec, you should be able to smile. Your ability to actually smile, right, is exercising certain
muscles.
Right.
So they are the facial muscles.
Okay.
So if one side is affected, you get one side shifted and your face droops.
Okay.
So that is one.
Right.
2, your arm. You should be able to move your arm and move it and move your legs too as well.
Right.
If you cannot do that, suddenly one side is weak and it's getting weaker, it can be a stuttering event as well. So if arm weakness or leg weakness, that is number 2.
Right.
Third one, S is for speech. So if I suddenly start stammering, I stammer normally. But if I start stuttering or my voice drools like I've got hot
a change in your speech.
A change in your speech.
Which is irregular.
Which is not usual. Then that something is happening as well. And then the T is time. As soon as you see these events, go. There are other subtle signs and symptoms of stroke which we miss.
Okay.
So memory deficit.
All right. Some kind of confusion.
Yeah, some confusion, a seizure, collapse, sudden collapse, sweating. I mean, there are lots of other subtle symptoms that we miss.
But these ones are critical.
They're critical
indicators.
They're indicators.
Okay.
Yeah.
Right. So if I see any one of these, I don't need to see all of them.
No.
Right.
Any one of these.
Any one of these. Do I need to know that the person has hypertension or any condition?
So there are risk factors.
Right.
The main risk factors, modifiable and non-modifiable. The modifiable ones which we can change: hypertension number 1, hypertension number 2, diabetes, high cholesterol, stress, alcohol, smoking.
Right.
And now let me add COVID-19.
Right.
It's a big major risk factor for stroke. They may not have any of the other risk factors of hypertension, diabetes. We are seeing it a lot of young people. So COVID-19 is a risk factor.
It's a risk factor
for stroke.
For stroke.
So good news to all those who don't want to get vaccinated. You have a 9-time risk of getting a stroke without even the other risk factors.
Okay. And
1 in 4 adults within their lifetime will have a stroke. There was a headline in the graphic a week or 2 ago. 25% of Ghanaians, I thought it was politicians, but 25% of Ghanaians or MPs or Ghanaians will have a stroke in their lifetime.
Right.
So that is very real. 1 in 4 of us. So 1, 2, 3, 4. 1 in 4 of us in our
25% of
lifetime
31 million people.
can have a stroke within their lifetime. So we have a lot of work to do.
Okay, we have a lot of work to do. If you have any questions, concerns, experiences with regard to stroke, you can join us 055 11 11 997. We're live on Facebook and YouTube. My guests are from the Kolebu Stroke Unit. It's one of the most comprehensive stroke units we have across the country. I know other facilities have them, but the complement of professionals in the team is something I'll talk about in a second, right? But you've got to get somebody who's experiencing the signs, facial signs, ability to smile, ability to raise your arms, move your limbs, and then changes in your speech. And then the T in the FAST, F-A-S-T, is for time. Get to a center that can make a conclusive diagnosis, hopefully, preferably using medical imaging facilities to conclusively diagnose the stroke. Right, let me come to you, Monica. You are part of a team. You are the matron, right? So there are nurses in the team. Who else is in the team?
So we have physiotherapists in the team.
Right.
We have occupational therapists in the team. We have a dietitian on board. We have clinical psychologists as well, speech and language therapists as well.
Right.
And the pharmacists.
Okay.
And doctors.
And doctors.
And doctors as well. Okay. We like forgetting you guys, you know. Right. So this is quite a comprehensive team.
Yeah.
So in diagnosing and coming about a conclusive diagnosis, you're all part of this process.
Yes.
Okay. So what's the nursing component, if I can, just tease that out for my listeners to understand? They basically tend to think nurses are running errands. There are plenty of them and they are all over the place. But you have specific things you're doing in this unit.
Yes. So we have a major role to play in the unit, caring for our patients.
Okay.
We do a lot of education. We educate our clients and their family as well about how to care for the patients after discharge.
Okay.
Yes. So
Right.
basically, when we receive our patients, we usually assess them. Stroke can affect your ability to swallow.
Right.
Stroke can affect your ability to talk. So we need to assess for swallow and know whether patient is able to swallow. If patient is not able to swallow, we have to put in an NG tube for feeding and medication.
Right.
Then we have to assess for speech. Are they able to talk? If they are not able to talk, we have to find means of communicating with our patients.
Okay.
So we adapt ways of communicating with them.
Right.
Either by sign language, by writing, or by using picture cards.
Based on your initial assessment, then you tune your interventions and your management to suit the patient's status or situation.
Yes.
Right.
Yes.
Okay. So, listeners, I'm sure you agree with me. I mean, if you've had a stroke, that's frightening enough. Now you've gotten to the stroke unit, but you cannot communicate, right? Nobody's even checking if you can swallow. People are sticking things all over the place, thinking they are feeding you or helping you or giving you something. We're hearing now that a proper conclusive assessment, in fact, comprehensive conclusive assessment needs to be undertaken by the team before they even decide how they are managing you and the things that need to be done. So you just heard Monica, she's a matron at the stroke unit. But Monica, you're also going to be dealing with family members, right, whilst you're caring for the primary patient. What is your interface with the family members as well?
Yes, so with stroke, we usually involve the family with the care. So we do a lot of education, teaching them how to take care of the patient after discharge. So we involve them with the care that we deliver at the units.
Okay.
And then we do a lot of education, preparing home after discharge.
Right.
And then how to do medication and follow up as well.
Okay. Right. So there's a lot of thinking and collaboration that goes into even thinking of your management and then, of course, planning for discharge. Because with the challenges that you have or the residual handicaps that you have, when you go home, your home is no longer the same place. It can become an obstacle course. It can become a risk factor in itself if the discharge is not planned properly. That's what you're hearing. This one says, Note, please kindly ask if a regular high BP reading is an indication or an indication to a stroke. I am hypertensive. If I take my medication regularly and my BP readings are normal, does it take away the possibility of getting a stroke? Albert, you want to take that?
So that is a risk. It's a warning sign that he must know his numbers. So everybody must know their numbers.
Right.
Everybody listening to us today, by the beginning of the week, go to your workplace clinic, go to a clinic near your pharmacy shop and check your blood pressure. It should be below 140/90.
You should have your own gadget, actually.
Your own gadget,
Yeah,
yes.
check.
So it's yes. So in COVID, you must have your own gadget.
Right.
You must know what your blood sugar is. You must know what your cholesterol
Know
is.
your numbers.
Know your numbers.
Right.
And you must know how to manage stress.
Okay.
Everybody is stressed, but it's how you manage the stress
Okay.
is what counts. And
Right.
talking about the discharge planning, we've seen that a lot of people are building houses with nothing on the ground floor. Please remember that one
We want to
in
get
four
closer to God.
of us will have a stroke in our lifetime. So please, after the building fair, Joy, everybody must have one room self-contained downstairs,
Right.
with a nice level,
Or get friendly with your landlord.
or just in case. Yes.
All right. Okay. So these are structural things, but
Things,
they,
yes.
they impact on the management
Yes.
of the stroke and the aftermath. So it's important to consider some of these things, right? Cynthia, I know Albert and I, we've lived this. So, but I know the challenges when it comes to stroke. My dad had a stroke, right? My mom had a mild one. Both are medical professionals, right? But when it comes to the physiotherapy aspect of it, what are we looking at?
Okay, so we are looking at prevention of complications that can come about as a result of prolonged lying in bed.
Okay.
So after a stroke, a lot of the survivors are not able to move in bed. And so what the physio comes in is to help assist and improve, and then also teach or re-educate the patient on how to safely move.
Okay.
Because lying in bed for a very long time poses a risk. The patient is likely to develop a DVT. Patient can also develop bed
Deep vein
sores.
thrombosis.
Yes,
right.
please, DVT. Patient can also develop bed sores. Patient can end up with contractures. So day one, when the patient is admitted, the physio comes in to assess the difficulty with the movement,
Okay.
and then plan with the patients and the caregivers as well. We also do a lot of education because we see the caregivers as a very important component of the care.
Right.
Now, once we do the movement rightly and the caregivers come in and then they don't move the patient rightly, it serves as a risk.
Right.
There's a way to move the patient's shoulder.
Okay.
There's a way not to do it. So once the patient is admitted, we engage the caregivers and then we educate them. We show
You
them
teach
how
them
to
how to
properly-
move,
Yes.
support movement,
Yes,
and so
yes,
on.
yes.
Otherwise, then they are working in conflict with what you've been doing.
Yes, exactly.
Right.
Yes,
And they need
yes.
to learn all this before the patient is
Before
discharged.
the patient is discharged. So
Right.
we make sure that they are able to do it safely, even whilst the patient is on bed,
Right.
and then plan towards going home.
Okay.
Assess the home environment, and then also plan the relatives, and then teach them how to also help move the patient safely at home before they are discharged.
Okay. Great stuff. 25 minutes past the hour of 2 on Joy 99.7 FM. The program, as always, on Sunday afternoon is Ultimate Health, your ultimate guide to healthy living with me, not it by nature. I'm in the studio with Dr. Albert Acquah. Monica Appiah is a matron with the stroke unit, and Cynthia Osei-Yeboah is head of physiotherapy. And they're taking us through the paces, what they do, how they assess, and the important things you need to know. We've heard critically that you need to know your numbers. I'm getting another one on my screen which says, my name is Tenyanu from Dodowa. When your BP rises to 205/130, what first aid is recommended? You're talking about first aid, huh? Is recommended before seeing a doctor, and can you also be home and just take rest? Hey, Tay.
No, please. Number one, no aspirin. So a lot of people who have this will go and take aspirin,
Right.
which may worsen an already bad situation.
Okay.
So you have this level. Make sure you're taking your medication and get to a facility where you can be checked out and seen. There's something that we call a TIA, or a transient ischemic attack.
Right.
So this is like a pre-stroke.
Yeah.
So this is a warning sign. It's also a risk factor to as well. So
Okay.
please don't take aspirin. Don't take it. Go take your current medication if you're hypertensive and go to hospital.
Go to hospital. All right. Right. Note, any stroke, please, Ghana should collaborate with Canada Sunnybrook Hospital in Toronto to learn their team system at the hospital, because the time is of big essence in saving a patient life. We've said that already. Symptoms: heavy lower leg, left or right, the read eyes when one wakes up, and so on and so forth. Right. I had one when doing therapy 3 years ago, no one should die from stroke. Sunnybrook Hospital in Canada have 15,000 doctors and students. Okay, right, we get that, and we also have loads and loads of qualified, experienced professionals as well. Collaboration is not a problem, and we are happy you're sharing with us. So we've talked about Tay with the 205 over 130. You want to sit at home? Come on. Right, we're saving lives, precious time, so time is ticking. 2:27. Right, so coming back to the physiotherapy aspect again, movement, function, and so on and so forth. They become risks if not handled properly. We hear of falls, we hear of all sorts of
shoulder subluxation.
Right.
Yes.
Okay, and this is because we have, let me call them unskilled labor, in quotes, handling relatives.
Yes.
We think we do not need specialized carers to at least train those at home relatives. What can you say about this whole business of training yourself to look after a loved one or a relative?
Yeah, and so when you come to the stroke units, we don't joke with that at all, because we don't want to come to a point with the patient and then the patient goes home and then comes back deteriorated.
Okay.
So right from day one, we engage the relatives a lot. We give them the knowledge. We allow them to try hands-on to make sure that they get it right before the patient is discharged.
Okay.
And then when the patient is discharged as well, we also help them to look around to see if there are physio facilities with qualified physiotherapists.
Okay.
Because there are so many quacks around. A lot of facilities have sprung up. Everybody is doing physiotherapy. But when you visit there, they are not qualified physiotherapists. Recently, there was a news item on Joy where a quack administered a sort of therapy to a patient.
Right.
So I want to use this opportunity to also advise the general public that be careful where you seek your therapy.
Right.
Make sure you seek it from
Even if
a
it is free and
qualified-
cheap.
Even if it's free and cheap, your health comes first.
Right.
Make sure you are receiving it from a qualified physiotherapist,
Okay.
a licensed one.
Right. Okay. And functional movement, right? And of course, you team up with the occupational therapist as well to now start looking at these interrelationships to make sure that quality of life is improved, enhanced,
yes.
maintained
Yes.
whilst you're looking after the
Yes.
person. Okay. If you have any questions, concerns, share with us. We have the honor of having the a good component of the Kolebu stroke team or stroke unit team. We have a neurologist, a physiotherapist, and a senior nurse with us. If you have any questions, concerns, you can ask us. Right. So Albert, coming back. So we've been able to follow. Thankfully we got to the hospital. A diagnosis has been made.
Yes.
Right. Typically, the person will require admission or
Yes.
inpatient treatment.
Inpatient treatment. So the ideal place to manage a patient with stroke is at a stroke unit.
Okay.
But if you don't have a stroke unit, we encourage all hospitals across the country to have a dedicated space,
Right.
2 or 3 beds at the side of the ward where we know the mattress is good. There's a Ripple mattress to help prevent bed sores and
Okay.
to move the patient. Staff are skilled and trained in knowing how to administer a swallow test,
Okay.
how to frequently turn the patient, and how to have an MDT approach. MDT is multidisciplinary team approach to the management of the patient.
Okay.
So it takes time. We didn't come here just by magic.
Right.
So it's taking
We've
us.
been building our
we've
capacity
been
to
building
manage
our
stroke.
capacity.
Right. Over
So we do rounds together. What happens in most places, the doctors come and do their rounds and then
They
go.
leave, right.
Then the nurses come and do theirs and go. Then the physio will have a referral, come and do theirs and go. But we work together as a team.
Right.
So as soon as you come, there's a multi-layer of checks,
Right.
multi-layer of interventions that are done.
Okay.
And there's a family education, and discharge planning starts the day you enter
Okay.
the ward.
Right.
So these are very important things.
Okay.
And people take these things for granted. So where are they going to? Person lives alone. Who is going to come and take care of him?
Okay.
Person lives upstairs and is 150 kilos. Who is going to
Sometimes
carry him?
they're just happy with the discharge because they stop paying bills.
We stop paying bills, but the
Right.
main work starts.
The trouble
Post-stroke
starts, yeah.
is not trouble; it's hard work.
Right.
It starts after the person has been discharged.
I like
So-
calling it trouble, so
yeah.
that people take it
So
seriously.
we try and do it as soon as you come in. We integrate you. We let you find one person in your family
Okay.
who is going to be in charge, who's going to help, and we start training that person.
Right. Okay, great. 31 minutes past the hour of 2 on Joy 99.7 FM. We're talking about stroke, and we're trying to silence the silent killer and save lives. Time is of the essence. When you experience a stroke, and we've talked about critical symptoms, that you should make sure as soon as you move to a facility, right? And all those things about going to church and people laying hands, please. They don't play a part in this.
Do it alongside.
Do it alongside. Make
Pray,
sure.
pour the
Yes,
libation.
make
chant
sure.
the- but come to
The hospital. Right. Hello, please can I get the doctor's contact numbers and talk to them? I have a stroke patient and I need assistance. So if somebody wants to contact the unit, let's stick to Kolebu for now. Is there a hotline? Is there anything people should do? Can you just appear at Kolebu and say, I heard Albert, where is he?
Well, we have a stroke clinic,
Right.
which runs on Mondays, so
Okay.
you have to be referred.
Okay.
Now, to get into the hospital, to get into the stroke unit, the hospital has an admission system.
Right.
You have to go through the emergency room,
Okay.
cleared, have a scan, and the team comes to take over
Right.
from there.
Wouldn't that swallow the 3 hours you're talking about?
Well, we've trombolized somebody.
If
who
I get
came
to the
us.
hang on.
Yes.
If I get to emergency at Kolebu
Yes.
and I say, look, this is a stroke or it looks like a stroke, do I still have to go through all those layers?
You still have to go through all those layers. These are barriers we are trying to deal with. So
Right.
that's why we need to decentralize. We have
Okay.
a unit in Confanoche, Dr. Prof. Safo's team. We have a unit at Ridge. We trained one at Lab that was pulled down.
Okay.
We have one at Whole Regional Hospital,
Right.
but they don't have a functioning CT scan. It's
Right.
private one. We need one in every region
Okay.
to improve the outcomes of stroke.
Okay.
We've had people coming from Koforidua, people coming from Cape Coast. We have a team coming from Sierra Leone to come in and study what we are doing, to
Okay.
go back and go and fix.
Right.
The
So we're
systems
doing
there.
some things which are working and those things people want to emulate. All right. Now, to kindly ask for the signs and symptoms of stroke. Sarah Manfo in Winneba, we'll go back over them. We've talked about some of them already. Not what does it say? How does not taking the COVID vaccine put you at risk of getting a stroke?
Okay.
What of the blood group type? Here we go. Does it prevent stroke? And the foods we eat. Douglas from DC. All right.
Okay, COVID-19 itself causes a hypercoagulable state,
Right.
or makes your blood thrombose,
More
or
likely to clot.
To clot.
Right.
So therefore, without even having hypertension or any other risk factors, your blood can clot, and that may be even the first symptom of CNS symptoms or you having COVID-19.
Right.
So therefore, the vaccination helps to prevent the COVID the
itself.
COVID-19
Right. Okay.
period.
And you mentioned 9 times. Douglas, take it seriously. And people are always
So
looking
you
for.
add 9 times
Yeah.
plus 1 in 4.
Right.
So if you're above 25, you have a 1 in 4 chance of getting a stroke.
Okay.
And add not being vaccinated.
Right.
And add smoking, alcohol,
Right.
stress, and
Okay, plenty stuff. But
Plenty stuff.
why is it that people are always looking for foods they can eat and avoid? And I know how it's related to stroke and hypertension and a few other things. But the question I got was, is there anything? Where's Douglas's thing? I've lost it now.
About
but
food.
we get
Salt.
Yeah.
so reduction of salt. We have something called the DASH diet. So dietary advice to stop hypertension. So decrease salt, more fruits and vegetables, increasing your fiber, reducing your fat content, reducing your carbohydrate content. So
Right.
basically, your plate should be colorful.
Okay.
So usually our usual rice is a big mound of white rice and small stew.
Yeah.
And no.
It's called quantity, not quality.
Quantity, not. So that is not colorful. So your plate should be colorful. And
Right.
our dietitians have a big role
Yeah.
to play in prevention, secondary prevention, and managing the stroke too as well.
All right. Great. Douglas is still asking for numbers. Douglas, if you've listened to Ultimate Health all these 17 or 18 years I've been doing it, I desist from doing that. That's not the purpose, right? We educate people. They go to the facilities, okay? So I know some programs do it. They give out the doctor's numbers, and that's not the way we do it professionally, okay? If there's anything...
I need to sleep.
we need to make sure that we get a brief. Then if there's a proper bridging with our guests, we do that, okay? Right. If you have any questions, concerns, 055 11 11 997. Please, this one says... time to get patient into hospital is just like a heart attack. Don't let the patient go through any steps. As soon as the patient arrives at the hospital, it's a priority. That's why I asked Dr. Palu that what kind of process. He says they are still working on some of those.
We have processes.
Right.
If there's a stroke,
Yeah.
patient identifies as a stroke. The emergency team and Kolobu is very good.
Okay.
There's CT scan is done immediately, and we can tell what type of stroke it is.
Okay.
And treatment is done.
All right.
What happens is that we have people holding the patients for a week or two. So if you come after a week or two, there's nothing much that can be done because there's complications have set in already.
Okay.
So time is brain.
Right.
There are other private facilities that are doing acute stroke care.
Okay.
We are a subacute stroke care, even though we can do the acute.
Okay.
We have thrombolized a few people. They've come within the 3-hour window. CT scan has been done. So that's where we have our neuroradiologists, the administrators. It's not only us, it's across board. We need more space. Our units, give or take 15 beds. If they are all full, it's full. So we have to have other facilities and other places to go.
Okay.
And there are other means of managing stroke.
All right.
Not only the acute, people who qualify for the acute thrombolysis, that's given the clot busters are maybe 10% of people, or less than 10% of people with stroke. But
Right.
what we can do are managing the blood pressure early, bringing it down slowly, managing the blood sugar, doing a swallow assessment, checking for further complications, starting early mobilization, reducing their risk factors.
Okay.
These all save precious time.
Right.
So we don't need high tech. This is a low tech approach which has found to work.
Okay.
And we've done a lot of work with that. So
Right.
bring the patient in early. Do not do a swallow test. Everybody should be able to do a swallow test. Do not keep them lying flat. Then visitors come. Everybody brings fried rice to come and visit. So they are lying down flat and they are pushing fried rice, hard fried rice. The patient will aspirate, get an infection. After visiting hours, patient is gone. Funeral.
Okay.
So
So that
we need
leaves-
to
Yeah.
increase the education.
Right. That means that the staff on the ward or on the team need to be hyper vigilant. Somebody's come, he's brought some water that some pastor has prayed over.
We get all sorts of
Somebody is trying to administer something.
Yeah.
Somebody brings a whole prayer warrior team. And Matron, how do you handle this? Right? Because it's a small unit, it's tight, and you have a lot of work to do monitoring all of these things and
Yes.
training and teaching and collaborating with family members. How do you balance this?
Yes, it's not very easy, but we are doing our very best. So always our nurses are alert and very vigilant on the ward, monitoring patients' relatives when they come in.
Okay.
We've been teaching them how to do feeding and all that, but whenever they are doing it, they do it under our supervision so
Okay.
that we can know what they are giving and what they are giving at a particular time.
Right.
So we go about during visiting time, trying to monitor the activities of relatives when they come around the patients.
African relatives don't like that. They give you a
Yes.
hard time, don't they?
Really, we really have a very
visiting
hard
hours
time.
and all these kinds of things.
Yes, we
Right.
have hard time handling that, but we are doing our possible best because we are there
Okay.
for our patients.
Okay. Right. If I may ask, so what's the staff strength on any given day in the stroke unit? How many
we
people?
are understaffed.
You're understaffed.
Understaffed.
Okay, so you are vulnerable and you could also get your own stroke.
Yes.
You are understaffed.
Yeah.
So, I mean, with all the benefit of all this empirical evidence that shows that if we do the right things timeously, we get better results and outcomes for people. Why are we still understaffed? There are people saying they don't have jobs. I'm just asking. So that becomes administrative, not clinical.
Well, so that's why they are also part of the. That's why they are also part of the. That's why they are also part of the multidisciplinary team.
Okay.
Because without them, so to get them involved, they have to. So like the Ministry of Health is making efforts to. They celebrate World Stroke Day, but I think it ends at that.
Okay.
We need to put systems in place.
Right.
We are building hospitals without stroke
Specialized units.
Specialized units.
Right.
We are building hospitals without a CT scan. We are training staff what should be done, what can we do, what can we put in place. So there's a lot of advocacy. The African Stroke Organization, we just had our first meeting, is trying to put these barriers and identify these barriers and look at the health-seeking behavior of the Ghanaian. Let me put not the African, of the Ghanaian. Somebody has a stroke, drooping of the face. The first, we do not look for what caused it, we look for who. Means somebody, a ghost has slapped you, somebody has slapped you. So they go around finding who caused the stroke, not what caused the stroke. So we need to come in early, save precious time. Come in early, and we can help to improve your recovery.
Okay, right. I'm going to activate the phone line 0302-216-541. Those of you calling the WhatsApp number, sorry, we don't take calls, video calls on the WhatsApp. We need it to read your messages out and then get the responses. Hi, Naughty. Please, my dad had a stroke for 2 years now. Half of his right side, head to toe, is working, but he can walk. He can't use the right hand. So this is something from hemiplegia, right? He can use the right hand to eat. Please, is there any help? Right? So half-sided paralysis, functional deficit on one side. He's had a stroke, I guess, 2 years ago. And she's asking if there's any help. So if you were not managed at Kolebu, can you bring such a person?
Yes, you can still bring such a person.
Right.
You can get a referral from any peripheral clinic.
Okay.
And then walk into Kolebu.
Great.
Or the physiotherapy department. There's still a lot of help.
Okay.
Even after 2 years, recovery still continues.
Because we're doing rehab.
Even though it's, it slows down, but then it still continues.
Okay. Right. Naughty, this is Daniel Osekre from Amasaman. Do frequent muscle pull, or is frequent muscle pull a sign of a stroke?
No, so it depends on what he means by the muscle pull. So there are lots of other early warning signs.
Okay. Good afternoon, Naughty. Good topic to discuss. Please, I feel something like insects walking inside and around my face and inside my head. Is it a symptom of a stroke? I learned it's something like that. That. Ajwa, this is from Ajwa, Sewa, and Kaswa.
So small insects is called formication. So it's a sign of a neuropathy, a peripheral nerves.
Okay.
So if it affects a certain part of your brain, it could be.
So it needs to be investigated.
It needs to be investigated.
Okay.
Yes.
Ajwa Sewa, please have yourself checked at a facility. This one says, my dad is suffering from stroke-related attack, but he doesn't want us to send him to hospital. He wants to be on herbal medication. What can we do? Yes. Any of you? Matron, I'm sure you hear these things.
Yes.
We are doing herbal.
Yes, so we always advise them that the herbal does not really help. They have to come to the hospital and seek for immediate medical care.
Okay.
So Matron, there are two ways of this. So the Ministry of Health is trying to promote herbal medicine.
Okay.
So whichever one you are doing, you should maintain a structured herbal place. But we have all sorts of places where they are drinking gallons, pouring gallons, bent twine gallons of things into you. So that is where we have a problem.
There's this feeling, Albert, that herbal, once you say herbal, it doesn't need regulation, it doesn't need evaluation, it doesn't need checking.
We have good regulation.
There's a science to it.
There's a science to it.
Yes.
The Mampong treats stroke. There are other good herbal places.
And they have an association.
They have an association.
And they are represented in the ministry as well.
So they can say, they also do CT scans. They do. They need to know what it is. But it's the other unregulated places. So we have people who we've worked on going home, power has improved, and then they go to an unregulated place and come back worse off than they even left. And their wives are the ones who usually get those problems. Because they bring your husband, whether if you didn't take him, you have trouble. If you take him and there's trouble, they'll bring it back to you with trouble. So
I have a caller on the line. Hello.
Hello, good afternoon.
Afternoon. Who's speaking, please?
Douglas.
Douglas from DC.
Sure.
Yeah, your question quickly, Douglas.
Yeah, concerning the blood group and the food. There are some blood groups, it's highly attacked before, how do you call it? It's very strong before diseases will attack some blood groups.
Very strong before what used to attack which blood groups?
For example, let's say O positive, that those high blood people group.
Just hit your question quickly so that we can get a response for you, Douglas.
Okay, so does those blood group prevent stroke? And then the food intake, there are some either carbohydrate or those food, does also
All right.
stroke in our food intake.
Right. We've talked about the food. Thanks, Douglas. You know, we've done this with the dietitians. We had a whole spread with Wise Lecha. So we know the food groups, right? So, yes, the foods that are high risk have been mentioned. He's mentioned salt intake. He's mentioned alcohol. He's mentioned a balanced diet and so many other things. But let's deal with the blood group, Albert. He mentioned...
So there's been a lot of talk. People have written books of eat right for your type and exercise. People with shouldn't eat maize or shouldn't eat this.
Right.
The bottom line, the modifiable risk factors we know: hypertension number 1, hypertension number 2, cholesterol, alcohol, smoking, and the other newer coagulable risk factors which are now coming in. The ones we can't do anything about is family history.
Right.
Please, if you have a family history of stroke, uncle, auntie, father, mother, sister, please check your numbers. It's sad to see. This week I've seen a father, a son, and another uncle,
and the Holy Ghost,
and all comes through. So please, know your numbers.
Okay.
Being male is a risk factor in itself. Some you cannot do.
Men are more likely to get strokes than women.
As you grow older, the risk of getting a stroke is higher. But the modifiable, we can do something about. So let us reduce our stresses. Yes, blood group. There's no scientific.
The dietitians always, put that aside when they come into the studio, right?
So you forget about the blood group. Know your numbers. Get your numbers settled down.
Okay. Have them
physical activity
managed, right? Yes. Especially if you have any challenges. Hello, Noti. I'm keen on the timeliness in response. I live at Bachona, quite a distance from Kolebu. Where is there a nearer or appropriate facility in case of need? This is from Neil. Noti, I get periodic seizures during sleep and overcome the same after a while, sometimes with a struggle. Is that related to stroke? Albert, this is our territory.
Yes. So yes, people who have one of the causes of seizures is post-stroke.
Right.
So we need to find out why you're having the seizures and deal with that.
Right.
If you're in Bachona, nearest place with a CT scan and can manage stroke, C&J.
Right. C&J Medical Center.
Medical Center.
Okay. Right. Okay. So the facilities at the place you're charging to are also important. Unfortunately, sometimes we're so scared and anxious that we go to the nearest place. And this business of referral and shopping back and forth also wastes time, right? He's talked about the seizures, right? And because you get scar tissue as well, post-stroke, it can cause seizures. All right, great. 0302165541. Ultimate Health. We're talking about stroke with the Kolebu Stroke Team, represented today by Dr. Alberta Palu, a neurologist, Monica Apia, a nurse, and Cynthia Oseyeboa, a physiotherapist or physiotherapist. If you want to ask any questions, put them in now, WhatsApp or live on the phone lines, and I'll get you the answers. Right. Now, let's look at this business of rehabilitation. So we've gone through what many people call the danger period, right? Patient has been managed in the hospital. This whole business of discharge planning, right? We're letting you go home, which is good news. But what goes into that?
So ideally, for the best of places, from an acute stroke unit, you should go to a subacute and then another long-term place. But our social dynamics and our economic situation do not allow us to have those. There are a few places around which can do rehabilitation in course, but what are the outcomes?
Okay.
So we advocate that you go home. You set up your home environment with your family around you to start this process. It's hard work.
Okay.
So usually I'll stay 7 to 10 days, 7 to 14 days maximum. You need to get your place ready. So that's where the whole team sets into place. Everybody speaks the same language. So nurses, physio, everybody, this is a stroke. This is a hemorrhagic stroke. You have weakness of your hand. You cannot swallow. So what are we going to do?
So you're having a multidisciplinary
planning to this.
Okay, let me just take this call and then come back to this. Hello, good afternoon.
Afternoon, hope you're doing well.
Yes, I'm fine. Who's this?
Ajiman
Joseph. Right, share with us quickly. One question though, not three.
Okay. What has to do with the problem? Because sometimes somebody might do something, get a blackout. So
can you repeat that? What has stroke got to do with what?
Heart-related issues. Because if the heart is not pumping well, and sometimes you do something on your leg, you can fall. or you can get a blackout. For that matter, you cannot experience the stroke picking up for you to, or something to remind you.
Right. So you want to know the relationship between heart conditions or heart diseases and stroke.
So there's
okay.
plenty.
Right. Okay.
So there's a condition in the heart called atrial fibrillation. Your heart beats irregularly.
Okay.
That's a very big cause of ischemic stroke.
Okay.
So we look for that as well.
All right. So there is a link.
Yes, there is a link.
Okay.
So then the process kicks in. So matron comes in, physio comes in, OT comes in. What's your home environment like? Are you upstairs or downstairs? You have a bed. You need to have a hospital bed.
Okay.
You need a suction. So a list is given to you, and we try and give you time.
Right.
Sometimes people who have multiple families, that's where the trouble comes.
Okay.
With. So
now they're deciding where you stay.
Where you stay. So I have a very interesting. So I have somebody has 2 wives. In the morning, wife 1 comes, BP is high. Wife 2 comes, BP is low. So we start deciding where he's going.
Wife 1 is a factor.
Yes. So when it comes time to discharge, there are 2 ambulances, 2 groups of people coming. It's like a war zone.
So there must be cooperation.
So
right.
we need
amongst carers and relatives. Okay.
So we'll ask this a person who is with a tube in his mouth. I said, Mr. A, please, which house are you going to? And he uses this little finger to point to one place. Okay, then
and then the blows start in the ward.
Yes. So we say, okay, final word. He's going to this way, and he goes. So this is just a little tip, but where you go to, who is come to take care.
Right. It must be planned.
If there must be planned,
and there must be preparation. And resources put to it. Okay, great. Hello.
Hello. Good afternoon.
Afternoon. Who am I speaking to?
My name is Nanama.
Nanama, where are you calling from?
I'm calling from Accra.
Accra. Share with us. Right. You're welcome.
Yesterday. For some time now, I've been experiencing muscle pull in the night. And then yesterday in the morning, I was driving, then suddenly I started feeling dizzy. And I quickly rushed to the hospital. They checked my BP and it was 164 over, I think, 112. I sat down for a while and then it came down. The doctor made me do a CT scan, and it was clear there was nothing. I know that my cholesterol is high. I don't know if there can be any help.
Okay, right. So Nanama is sharing an experience. She gets what she describes as a muscle pull, and then she was dizzy. BP was a bit high. I think she went 154 over 120 something, but she was checked out. A CT scan was done. Yeah. She's okay. Is there anything else?
That's not the end of the story.
Right.
So she's still at risk. She still has to go back and follow up. That blood pressure has to come down. That cholesterol has to come down. We need to check other risk factors for her. So she needs to go back to see the doctor.
All right.
And then a clear normal CT scan at the beginning does not mean that she does not have any events. So there are other things that have to be done.
All right. And she's also aware of her cholesterol. Right. So she kind of knows her numbers, but now the interpretation and then the intervention is important. Okay. Right. Hello, Note. Please ask the doctor to explain hypertension. 1, hypertension. 2, this is from Auntie Della. So stages of hypertension, right?
So there are different stages. The normal BP is 140 over 90. There's something called even pre-hypertension, between 130, 140, and then the bottom, that's the top one is the systolic, bottom one is the diastolic.
Right.
The definitions keep changing.
Right.
But once your BP is above, between 140 and 160, 80, 90 to 100, that's stage 1, and stage 2 is above that. Whether stage 1 and stage 2, BP has to come down.
Okay.
Somebody can have a stroke at BP 130 over 80. So we need to know our numbers, keep our blood pressures down, and reduce our salt intake, increase physical activity, walk, reduce alcohol, stop smoking.
Okay.
And stick to one partner if you can.
Oh. Why are you looking at me in that tone of voice? Right, great stuff. We're almost out of time. Let me ask key important thing, parting messages from Matron for you. The most important thing you want our listeners to know?
Yes, so for now we are saying that time is precious. So we have to know the signs of stroke, and we can say it's stroke when we can say it's stroke, and then we rush to the hospital as soon as possible.
Right.
We also have to know our numbers. so that will control them. So if you are a diabetic, you are hypertensive, you have to know your numbers, be compliant on your medication, and do your regular checkups as well.
Okay, right. Compliance with medication, know your numbers, and use the knowledge of the numbers to do the right things. Cynthia?
I would want to say that always make sure that you get your therapy from the right source. Don't fall into the hands of quacks. Kolebu is there, Ridge Hospital, all the other regional hospitals have physiotherapy units. Make sure you don't fall into the hands of quacks.
Okay. I'm getting a lot of questions about, so I say, well-equipped facilities. This one says we are at Abotuasi in the OT region. Which facilities close to us? Go and check, right? If you're, because our dad finally agrees.
So OT region, the only CT scan function in the region is a private facility just near the whole regional hospital.
Okay.
Northern Ghana, none, apart from Tamale Teaching Hospital.
When you say the whole regional hospital, you're talking about Trafalgar?
Trafalgar, yes.
Okay, right. There's a
Just-
private
just
facility here.
outside of-
All right,
of that.
great. Can I get the recordings of the program? Yes, you can go and get our podcast, okay? You had 2 weeks ago about eyes. Quick, go to our site and check the podcasts. Quickly, hi, this is Mami Efua. I want to commend Dr. Palu and his team for their good work. God richly bless them. My mom had a stroke about a month or two ago, and they have been really helpful. This is from Mami Efua. So thumbs up to you guys. And we'll have to look at compliance with treatment and other things another time,
yeah.
right? The actual journey and the rehab. So many thanks once again, Dr. Albert Akpalu, Matron Monica Appiah, and head of physiotherapy Cynthia Osei-Yeboah from the Kolebu Stroke Unit. They are part of the stroke team. Maybe next time we'll shuffle the team and get the psychologists, the OT, and other people in there as well. Many thanks for staying with us on Joy 99.7 FM and listening to Ultimate Health, your ultimate guide to healthy living. My producer, Abeku Sankofi, and myself, thank you immensely. We hand over now to Bele for Sunday Rhythms. That's also bringing your pressure and numbers down. Stick and stay on Joy 99.7 FM. I'm out.